And in that, then I realized, well, I've worked in so many different settings. I've done the multidisciplinary. I've done the private practice optometry, working for somebody else as an associate. I've worked at the VA before. I've done the teaching, and the next natural step for me is then to open my own practice and do it the way that I want. So I opened an advanced dry eye center right from the get-go.
Welcome, my friends and colleagues, to another exciting episode of the I Give a Damn podcast, made possible by Fluorescene Media, the company behind ODs on Facebook. Today's episode is brought to you by Bausch & Lomb and the new Infuse Multifocal. If you are not super familiar with the Infuse line of contact lenses, they are designed to minimize dryness with contact lenses by utilizing what is called a pro-balance technology, which is quite fascinating. If you haven't read into it yourself, I strongly suggest you do. But the new Infuse Multifocal also includes their 3-zone progressive design, which helps deliver excellent vision at near and intermediate without compromising distance vision. I even recently just had a patient fit with these in the clinic the other week, and she found not only could she see her phone easily, but she could easily still see the 20/20 line on the distance chart. Plus, she also had excellent experience with comfort, as these lenses have a low modulus and a high moisture content, and I felt good because I know these lenses have a high oxygen transmissibility as well. In addition to this just being a quick and easy fit there in the clinic, I also like that they come in a 10-pack trial, as a lot of times, because our clinic is just really busy, we don't always have the availability for our patients to come back within like 5 days. If you want to learn more about the new Infuse Multifocal Contact Lens and its availability, then I urge you contact your local Bausch & Lomb representative. Otherwise, thanks again to Bausch & Lomb for sponsoring this episode. In today's episode, we're diving into the world of ocular health and dry eyes. We have a very special guest with us, someone who's not only a respected authority in the field, but is also deeply passionate about ocular surface disease. Joining us is Dr. Hardeep Kataria, ODFAO, a true trailblazer in the world of eye care. In this episode, we'll explore the remarkable path that she took to discover her own passions for the management of ocular surface disease, along with what inspired Dr. Kataria to embark on a mission to start her very own specialty dry eye center right from the get-go. But that's not all, because today Dr. Kataria also shares her insights into some of her favorite advanced dry eye treatments, such as amniotic membranes, IPL or intense pulsed light, thermal pulsation, and even platelet-rich plasma. So stay tuned as we uncover what it takes to rise in the subspecialty of ocular surface disease management and the innovations that are changing the way we see and manage eye care. Without further ado, let's jump into this engaging conversation with Dr. Hardeep Kataria. Hardeep, thank you again for being here. This is a huge honor. Really pleasure, because we've met each other a few times at different conferences, but we've never had a time to really sit down to get to know each other a little bit better. And I know you have just a really interesting story of your education, kind of how you ended up jumping from different parts of career, like different parts of optometry, and then now you even have your own practice, right? So for people who have not read about you, seen you present, would you please just give us an introduction of who you are and how you practice, how you even got to where you are today?
Thank you so much for having me. Yes, so I graduated from the New England College of Optometry, and then I went on to do my residency at the Baltimore VA in ocular disease. And there was a huge emphasis on posterior segment disease, retina disease, glaucoma, and I was really grateful for the opportunity to work alongside the ophthalmology program at the University of Maryland. And even going into optometry school, I knew right from the get-go that I wanted to focus on medical optometry, and that came from my shadowing experiences when I was an undergraduate student, and really understanding that optometry has a role in medical eye care outside of surgical intervention. And so, I really focused even my school career, having my rotations at Bascom Palmer Eye Institute, and then having the privilege of working with top optometrists in the country at the Baltimore VA, and then ophthalmologists at Wilmer. And I was really grateful for that experience, because it really prepared me for the career of medical optometry that I had set out for myself. So then after graduating from the residency program, I moved back to Florida, which is where my family had moved us after moving from England in 2001. And my parents were still in Orlando, so I moved back there and wanted to explore what ophthalmology opportunities were available to me. I found myself actually jumping around a little bit to really figure out what would be the right setting where I would be happy. I tried working in a solo ophthalmology practice, which didn't work out for me, and then even in a multidisciplinary setting. And then I was offered a position to teach at the Western University College of Optometry in California, which is now all the way on the other side of the country. And so I packed my bags and moved, and I thought, right, if ophthalmology is not working in Florida for me, perhaps there's something in California.
Right, East Coast, West Coast mentality.
Maybe something worked because I'm still there. So I guess it was meant to be. And then from that position, I was recruited by a retina practice. So it was a sole practitioner, a retina specialist, really focusing on surgical retina, and he had just lost his comprehensive ophthalmologist, and so he was really looking for somebody to come in and manage mostly his medical glaucoma. And this was actually a great position for me. I learned a lot in terms of managing these advanced cases, and then from there, that glaucoma clinic, my advanced dry eye clinic was born. And we always say you cannot have a glaucoma clinic without identifying and treating the ocular surface disease that inevitably goes along with that.
Right.
And that's how my passion for ocular surface disease started, and it's just been growing exponentially since then.
I think that there's a lot of just amazing lessons about that, especially because the harsh reality of being like a new OD and just feeling out what you want to do. I know for myself, I kind of had that mental picture as a student that I was going to go straight into the clinic. Right out of school, I was going to get one job. That was going to be for the next 30 years, and I would retire, sort of thing. But then, you kind of test things out. You find out that not every clinic runs the same way, and you realize maybe your personality fits a different type of structure for clinic. And I think it's great just to hear from somebody that's also had a similar experience, just trying different things.
Yes, absolutely. And I think that's very fair. I think the traditional mindset is that we come out of school, just like you mentioned, we're going to get one job and we're going to stay there. Or sometimes we are led to believe that we have to stay there because we're going to be unhireable in the future if we jump around from one position to another.
Right.
And it's a very traditional mindset. I think maybe it was relevant at some point, maybe a few decades ago. But I think now, even from an employer standpoint, because now I am a private practice owner and an employer, I can really appreciate that, as a young graduate, it's really about finding that right fit. And it's a journey. Everyone's journey is their own. And I think just appreciating that journey is, it really helps to form that career arc that you're trying to create for yourself.
And I think in many ways, there shows some level of maturity in that you are trying to find something that you really love and something that you are passionate about, rather than sticking with a job that you're unhappy with, you're burnt out with. If it's really not your passion, then unfortunately your patient care is probably going to suffer too.
I agree. And also your mental space. I think even from a mental health perspective, which we really should focus on, I think it can deteriorate very quickly if we're not happy doing what we do 10 hours a day.
And so with you now owning your own practice, like you said, you're a business owner, that's a whole different skill set, whole different mindset. How did you go from, could you fill us in on how you made that decision that you were ready to step into being a private practice owner, to have the courage to do that? What were some of your motivating factors?
Yeah, absolutely. When I was hired at the retina practice, it was really, again, for the glaucoma emphasis and the medical management. And then I started to become so interested in ocular surface disease that I developed the advanced dry eye clinic. And I was very happy doing that, bringing in advanced procedures, thermal evacuation, microblepharoexfoliation, and just really setting that up, exploring advanced therapeutics, amniotic membranes, medications. And I was very happy there for a while. And then towards the end of my journey at the retina practice, a cornea specialist was brought in. So somebody was really focusing on anterior segment surgery, except that he was more interested in managing ocular surface disease rather than actually surgical intervention.
Which is a little interesting.
It's very interesting.
Yeah, you don't see too many of that.
Yes, and what that really helped me realize is that I'm replaceable. I'm not valued here. I was at one point, and I was very grateful for that because I brought in value to the practice and profit to the practice. But I also took from that because I was able to see very advanced cases and manage those and co-manage with different subspecialty surgeons. I was very grateful for that experience. But my time had come to an end because I realized just how replaceable I was when somebody came in and started to, overshadow my management of ocular surface disease. And in that, then I realized, I've worked in so many different settings. I've done the multidisciplinary. I've done the private practice optometry, working for somebody else as an associate. I've worked at the VA before. I've done the teaching, and the next natural step for me is then to open my own practice and do it the way that I want. So I opened an advanced dry eye center right from the get-go.
Which is pretty unique, I would say, because most people, they start really small. They just maybe open a very general clinic, whether it's just like one lane, and they do glasses and they do some contacts. But you went straight into like, nope, we're going to start with this specialty clinic. Yes. Which I think is awesome.
Yes, exactly. And that was the goal right from the get-go. I was already doing what I loved in terms of patient care and clinical care. It didn't make sense to me to open my own practice and then not do what I loved. Isn't that the point of being in private practice? I can do things the way that I want to do them. And so really it was about carving that opportunity for myself. It wasn't an easy decision, and it wasn't a quick one, right? My parents would ask me, right when I graduated residency, right, so are you opening your own practice? And I wouldn't even let them finish the sentence because I didn't feel prepared. I felt like I needed a business degree to even understand how to operate my own business.
Right.
And I had no business savvy, or what I consider business savvy. I probably still don't have enough, but I'm growing and I'm learning, and I'm okay with that process, that learning curve. And so I used to just shoot them down and say, nope, we're not even having this conversation. And look where I am now. But I appreciate that journey so much, and I do not regret one day of not being in my own private practice. I do not wish that I had done this sooner. And I say that because I wasn't prepared at that time, and that's okay. It wasn't the right time for me. This is the right time for me, and I've identified that, and I'm okay with it. Had I not had the experiences and the journey that I had taken, I don't think I would have realized that this is the next natural step. And so I'm so happy with the journey. I honor my journey, and this is what was meant for me, that I had to go through all of these hoops and all of these obstacles to find now what I am truly happy doing.
I think that is honestly so powerful, I think, for people to hear, even for myself, because I definitely feel in our profession, there seems to be an underlying tone or pressure to open your own practice. And I think there's certainly a benefit in the optometric world that you can do that.
Yeah.
But it's certainly not for everybody. Like you said, there's a skill set. It's a whole other profession to know how to run a business. And there are a lot of nuts and bolts and just the logistics behind how do I purchase a building, or how do I rent a building? How do I outfit the building? What instruments am I going to pick? How am I going to employ somebody? How does that work with the state? How does that work with OSHA laws? There's a lot of things to get in just lined up, let alone the reality of taking out loans and taking that financial risk.
Yes.
So, and I think just that self-awareness that you weren't ready before.
Yes.
And now I would say, again, that maturity of like you going through these steps in your career and understand, just like those experiences set you up where now you're even more motivated and passionate of knowing exactly what you want to do and what instruments you want to start with, which I'd love to hear more, just kind of knowing that you were going to start this type of level of care off the get-go. What instruments did you kind of know you wanted were like the number one things you needed?
Yes, absolutely. So given my experience in setting up the advanced dry eye clinic, I knew that I wanted some way of imaging the meibomian glands. I needed to have a meibographer right from the get-go so that we understand that most dry eye disease is due to meibomian gland dysfunction. And having that experience, I understood that how powerful it is as a patient educational tool to be able to show them the pictures, right? And show them this is what you have. It's very ambiguous. It's very difficult to talk about meibomian glands for me without showing them the picture. So that was a non-negotiable for me. Having an anterior segment camera and investing in that software, that technology on my slit lamp. So, I knew I wanted a specific type of slit lamp, and that's exactly what I was able to get. And that was another non-negotiable. And I can make those decisions.
Yeah.
Because it's my money.
Yeah, it is.
And then being able to offer in-office what we know is like traditionally step 2 treatments according to the TFOS 2. So thermal evacuation of the meibomian glands and microblepharoexfoliation. I didn't start right out the gate with an IPL, from day one.
Sure.
That was, a purchase that I made a few months in. So still relatively early because I knew I knew what value it would have, but it wasn't, I need to spend X thousands, hundreds and thousands on this technology. I started slow. I started with my non-negotiable, the meibographer, the anterior segment camera, some level of meibomian gland evacuation, microblepharoexfoliation. I also knew that those worked for me in the past. And there was really low barrier to entry for patients in terms of that treatment. And then also getting on medical insurance panels, knowing from the get-go that I was going to be managing patients for medical conditions. And you can't do that without accepting medical insurances, especially where I am.
Yeah.
And, the goal was never really to be cash-based, but rather as a cold start to be able to capture everybody.
Right. Make it improve the accessibility to you and your knowledge, your services.
Exactly, right. And so getting on those medical panels, enlisting a credentialing company who would help me do that in the way that I needed that to be done and in a timely manner was very important to me. And then even the planning phase. So my space was a vanilla shell and it had no walls. We made those walls. So even planning where I was going to, number one, put my treatment modalities, not only now but also in the future. Where is my machine? Where are my machines going to sit? And where am I going to perform those exams? How many slit lamps am I going to need in each? Is it going to be just 1 or 2? And just planning architecturally where I would be performing those treatments and where I would be performing exams. Yeah. So right from the get-go, that mindset was there, and it helped me to really set that up right from the get-go.
And I think that's probably even better because you can make it all, like it probably costs some level of income or for investment to outfit it the way that you envision or want it, but at least it's yours. It's not you walking into some other established building and being like, okay, I'm just gonna have to make it work, which is okay, and I'm sure people do that all the time, but there's something that's very personal, and again, your passion kind of flows into it.
Exactly. And then if I make a mistake, I can learn from it, and I don't have anyone else to blame but myself.
And again, that's the mindset I also really admire, is that it's okay to make a mistake, and I'm going to learn from it. I'm going to just keep climbing, right?
Yes, exactly. It's so important.
With like your experience, I know you mentioned earlier like biologics, amniotics. Do you do those a lot?
I do. And I try to really emphasize intervening early with biologic treatment. I really believe in the natural healing power that our bodies confer in terms of ocular surface disease. So we have so many powerful tools that are available to us. We have amniotic membranes. We have so much research that helps us understand not only is it helpful in dry eye disease, but also dire consequences of dry eye, sometimes misdiagnosed dry eye, but really neurotrophic keratitis. Yeah. And coming from a glaucoma clinic, we know, and a retina clinic especially, we know that these patients really can suffer from misdiagnosed or underdiagnosed neurotrophic keratitis. And leaning on our own body's powerful healing mechanisms with tissues that are derived from the inner placenta, like the amniotic membrane or recombinant human nerve growth factor that we now have available as FDA approved, and we're seeing so much more data that supports the use. And even considering autologous serum and platelet-rich plasma for our recalcitrant different dry eye patients. And I think traditionally we used to reserve these treatments until we had thrown the kitchen sink at the patients. Now we're frustrated. Patients have been frustrated for probably years at this point, but really emphasizing we don't have to save up. We don't have to keep those in our back pocket. We can introduce them earlier, because we're in the business of saving eyes and saving vision, and to intervene earlier means that we're preventing disease state progression.
For sure.
And I think it's very powerful.
And potentially, saving even potentially financial dollars for the patient too.
For sure.
Because you may be deciding, I'm just going to try this medication for 6 months. Well, that's 6 months of investment, medication, and just waiting time just to find out that we're not getting the response that we wanted, when you might have gotten a better response just starting off with like a membrane placement.
Absolutely. And our patients are not waiting 6 months anymore. We're not waiting 6 months for anything. We want results at our fingertips.
Yeah.
And I think this is the reality of what we're dealing with patient care now. And some of these treatments, they give us immediate results. And we can't forget the benefit that we're preventing disease state progression. If we identify mild to moderate dry eye at an early stage, we can prevent that patient from developing NK in the future. And we understand that NK has dire consequences, because it might not just be stage 1 NK at that point. Those patients start to ulcerate and they lose vision, and that can be frightening.
Absolutely. And I think for myself, when I started learning, especially when Oxervate first started coming out and I started reading a little bit more into it, I started realizing what stage 1 NK really looked like. And I started realizing, wow, that looks a lot like a lot of my more severe dry eye patients. Yeah. And I'm like, am I missing this? Right. And so then I started incorporating and instructing my students at our clinic to do a lot more sensitivity testing. Yeah. And certainly enough, now we're catching a lot more of it. And so I think that's great. Do you typically just do a cotton wisp test? Do you use crochet bonnet? What's have you?
I just use a simple cotton wisp. Yeah. Yep. It's so easy. It's so accessible to me. And I perform now corneal sensitivity testing on all patients coming in for a dry eye evaluation, so that we're starting to think about this right from the get-go. We're not waiting.
And I think also from just my experience in like the social media world and things like that, I still see so many people post about how I went to like my 3rd dry eye specialist and they didn't do any testing that I haven't seen before, and it was always just fluorescein staining. And you certainly can use that. I think it's a great place everybody kind of needs to start, and we kind of learn that baseline in school. Yep. But now I think even patients, especially frustrated patients, are expecting more. And yes. I think those, like you mentioned, photographs of taking some sort of imaging is important, because these are patients who are frustrated. Yep. These are patients who have been suffering. And even if you have some weird pain in your knee or some other disease, you go in to see your medical provider and they do an X-ray or an MRI, and you hope to gosh it's not something like cancer. But sometimes just knowing what the enemy is, just it makes it a lot easier to deal with, because you know that there is a problem. Because then you do MRI and like everything looks good. Why are you in pain? I don't know. Like that stinks. Yeah. So I think that's great. With right now, are you doing a lot of Oxervate? I'm curious, because that's still a fairly new medication.
Yes, I do, actually. I think, I'm still using a lot of combination treatment. We have to layer treatments. So, it's very important to treat comorbidities and really identifying those up front. So if a patient does have an MGD component or blepharitis component, getting them plugged in right away with treatments for that, having nutritional support, really understanding that multifactorial etiology, and then intervening early, maybe using an amniotic membrane as a bridge until we're able to get the synegemin on board. And then, yes, definitely using synegemin almost to have more long-term treatments. I think traditionally, before the advent of synegemin and before it was available to us, I used to, use the power of the amniotic membrane that's very rich in nerve growth factor, and then maybe lean on autologous serum as maintenance therapies. And I have many patients who are still on that treatment regimen. And now we're starting to see the increased use of synegemin to build on that concentration of nerve growth factor.
And I'm curious, because you've mentioned a couple of different treatments, and
Certainly amniotics are amazing, and I have experience with both the cryopreserved and the dehydrated. And there's some, if you ask different practitioners, they have different views or experiences with both. Do you use both? Do you have one that you prefer? I'm just curious.
Yeah, my journey started in amniotic membranes with dehydrated, and I didn't have a great experience. I remember those patient names so well because they had significant complications. That was my experience with the versions that we used. Corneal abrasions, we had, bacterial keratitis patients. So it was very difficult, very traumatizing for the patient, also me. So then I started investigating the cryopreserved amniotic membranes, and, I've just had superior success. It's just been fantastic for me, and I really believe in the technology that Dr. Sheffer Singh has created. Not only, cryopreserved amniotic transplant started their journey in surgery. And now we're starting to see, well, not starting, but now we're really in the thick of using it in non-surgical applications. And I'm just grateful that we have cryopreserved amniotic membrane, and my results and my experience has been superior compared to the dehydrated. Of course, accessibility sometimes can be difficult. Those are challenges. We have to balance that with cost and reimbursements, and we have to deal with that reality.
Right.
Yeah.
And then just the patient's nerves of having something placed on the eye.
The discomfort, and I always tell patients, look, I don't like going to the dentist. Can't imagine you like going to the dentist,
There's a reason I'm an eye doctor, not a dentist. So.
And sometimes medical treatments can be uncomfortable. But we are going to see the light at the end of this. We're doing this for a reason, and most patients are very successful, and they have success long term after using amniotic membranes. Or sometimes it's bridge therapy where we really need to stabilize the epithelium before we do surgery, for example. That rapid resolution that we're able to get with an amniotic membrane, we're not going to see that with immunomodulators or some of these other treatments. And then there's the question,
it's going to take a while.
Absolutely, right. And then there's a question of corneal nerve damage, right? Is it going beyond the epithelium? Is there a reason that this epithelial defect keeps reopening? And because we have sick nerves, and we don't have in vivo confocal microscopy at our fingertips. That would be really cool if I did. I guess I could make that decision now that I'm a private practice owner.
Yeah, and I know of a few famous ophthalmologists maybe who have that. I don't know.
Academic institutions.
I really don't know many clinics that would have that.
Absolutely, exactly. And if you're doing research, that's great. Otherwise, as practitioners in private practice, we're leaning on that research to help us understand that relationship between the corneal nerves and the corneal epithelium. When we're doing corneal sensitivity testing, it really helps us as a tool.
It's a functional assessment.
Yeah, exactly. So I think when we go back to the definition, the TFOS-DUSU definition of dry eye, we see neurosensory abnormalities is in the definition. Sometimes I think that we take that definition for granted because we kind of skate over that multifactorial, right? Everybody can recite the definition of dry eye. It's multifactorial, inflammation, hyperosmolarity. Neurosensory abnormalities is in the definition of dry eye. So we really cannot diagnose dry eye without considering the health of the corneal nerves, and therefore then the epithelium and so forth and so forth. Yeah, it's
there's so much we could spend talking about this. Being that I have a passion and interest in ocular surface disease as well, you mentioned autologous serum and also was it RPR?
Platelet-rich plasma.
Platelet-rich plasma. Autologous serum is something that I have some experience with. It's been around for a long time, right? Always kind of reserved as kind of a last ditch effort in a way.
Yeah, agreed.
I've personally had mixed results with autologous serum, but I haven't had much experience with platelet-rich plasma.
Yeah.
I'm curious, can you fill us in for other doctors who maybe aren't as familiar like I am of kind of what that is, and kind of just your experiences using it?
Yeah, so I think that so both are biologically derived eye drops, so both coming from our own bodies. And with autologous serum, the preparation between the autologous serum and the PRP, the platelet-rich plasma, is going to differ because the blood isn't allowed to clot in the PRP because we're adding an anticoagulant. So then when it hits the surface, those clotting factors are released, and that's when you're getting the growth factors from the platelets being released onto the ocular surface. And there's actually quite a body of research that now helps us understand that PRP can be more effective in some subsets of dry eye, especially when it comes to dry eye that's associated with autoimmune disease like Sjogren's. So there's some idea that when we have a pro-inflammatory response systemically from an autoimmune condition like Sjogren's syndrome, we have elevated pro-inflammatory markers in the blood. And we don't like to put those patients on autologous serum because we're transferring those pro-inflammatory markers.
Just putting that right on.
Right, exactly. And that's when we start to lean more towards platelet-rich plasma. And I do wish that PRP was more accessible and more available to practitioners, where we could say, you can have a blood draw, this is the exact protocol that we're using. And that hasn't been established. And that, I think, is the biggest challenge when it comes to using PRP. So yes, there's definitely clinical application, but the accessibility is quite reduced. And that's the biggest impact that I see in my practice. It's easier for me to access autologous serum. So that's the first one that I'll reach for. But if this is a case where the patient is not going to be a candidate because of, I've had patient cases with juvenile rheumatoid arthritis, for example, with very severe and advanced dry eye, or Sjogren's syndrome, I'm concerned about those pro-inflammatory markers, and so I'd rather reach then for the PRP. But in my area, these patients have to drive 100 miles to get access to platelet-rich plasma. Sometimes that's not an option for patients. And then, of course, there becomes the question of what's the concentration? Is it 100% PRP? Is it less than 100% PRP? Are we diluting it? If so, what does that process look like? So that protocol of making the PRP is still a little bit elusive to us.
Sure.
And we have great leaders, optometric leaders in the space in the United States who are great dear friends and colleagues of mine, who are in their offices actively working on these protocols.
That's amazing.
And hopefully we'll see some published data in the future. But just even to have some guidance on how to do that, how to set that up in our offices so that we can make it more accessible for our patients.
And I think that's for as long as autologous serum's been out, that's been a frustration from the get-go with autologous serum too, is just how do we get somebody to like a compounding pharmacy, or are they going to do a blood draw? How do we set this up? And then you get percentage arguments, what percentage to go with. So thank you for just filling me in on that information, because I haven't read too much into it. I know I'm aware of it, just haven't read the studies. So that'll be my homework assignment, right?
Awesome.
Right now, again, there's so much in the world of dry eye, ocular surface disease. There's some exciting new medications coming out. In fact, I'm sure you're aware of the new MIBO medication from Bausch and Lomb, right?
Yes, I heard.
They produce it. Are you familiar with that one at all?
I'm not too familiar with it.
Okay.
I'd be excited to learn about that.
So are there anything else? I know that's one that I'm interested in. Is there anything else just on the near future that you're kind of excited about, or something new you plan on bringing into your services at your clinic?
Yeah, so I'm very excited about developing the aesthetic sides of my clinic.
Oh, yeah.
And bringing in a practitioner who can really help us hone in on purely aesthetics outside of dry eye, but then also combining the two, because there's such a significant overlap. So we're already addressing the aesthetic component and dry eye when it comes to treating with intense pulse light and low-level light therapy. So we're already doing some of that in the office, but really honing in and being able to provide, maybe microneedling and radio frequency, and kind of bringing some of those in, not only from radio frequency from a dry eye standpoint, which can be great adjunctive therapy for dry eye and MGD, but then also addressing the aesthetic component. Because, when you start to get into IPL, when I'm doing my IPL evaluations, patients will ask me, oh, is that the same laser that my dermatologist talked to me about once for pigmentation? And they're very excited about, oh, am I going to get this skin tightening effect? And what exactly is the aesthetic benefit around my eyes? And then they start asking me about wrinkles and Botox at the lateral canthus, and it just goes on from there. So we're excited about developing that at my Cold Start. And that was something that I really wanted to get going with from the start, from the beginning. So that's the next project. I've already started with just last week, a medical grade skincare line to address some of that aesthetic component.
Right. There's only a few of them out there. I know it's the whole cosmetic and that whole thing is definitely an emerging trend.
Yeah.
And it's something I'm keeping an eye on, but
yeah, it's definitely an area to keep an eye on for sure. It's a hot topic for sure. There's also a lot to be learned. I think I think the biggest lessons that we've learned maybe in the last 5 years is, when we started our journey with dry eye and cosmetics and aesthetics, we started really honing in on individual ingredients that we thought might be damaging the ocular surface or meibomian glands. We understand that prostaglandins are not so great for the meibomian glands, but what about further than that? Looking at EDTA, preservatives and parabens and some of these other ingredients in our cosmetics. And, I think when we started out with this, we wanted to hone in on almost like a black list of ingredients. If it has this ingredient, it's a no-no. And as we develop our understanding, I think now what we're understanding is that these ingredients in certain cosmetic products that we're using on the skin, around the eyes, are there for a reason. Some of these preservatives need to be, and depending on their biochemical composition, their concentration, how they interact with other ingredients is so important. And we have to look at the cosmetic product as a whole, rather than isolating one ingredient and saying this brand is an absolute no-no, right?
Sure.
Or this product is an absolute no-no. But really now understanding, I think our understanding is still developing in that. And then I think we're moving away now from blacklisting certain ingredients, but now understanding how does that product interact with the ocular surface as a whole? How is my individual patient doing with that specific product? I mean, some products we know, like prostaglandin analogs in lash serums, we know that's a no-no. So that's established because we understand that from our glaucoma research.
Yeah.
But some of these other ingredients we're still learning. And I love that we're still learning because it's a growing topic.
And that's something that I know I've touched on with some patients, and I have to kind of fall on a few published papers and research from other professionals in the space. But yeah, just tell them like, well, it's something that we're aware of now, and there's publications coming out, and we're just learning. Yeah. But there's clearly something more going on, and do you think that's one of the reasons why women? Do you think it's more of the hormone change, or do you think perhaps different cosmetics is a reason why a lot of females end up historically being diagnosed with more dry eye and ocular surface disease earlier anyway? I
agree. I think that historically we used to think that the hormones are playing a large role, and that's undeniable. And we really understand how estrogen plays a role in the meibomian glands and developing dysfunction of them. But now we're seeing meibomian gland dysfunction happen a lot younger, and we can't ignore that cosmetics do have some sort of effect on the ocular surface. And I'm excited to see the published paper, the lifestyle report, that is slated to be released, I think maybe next month in July sometime. I think Sweet. It's going to be released. I'm really excited to read that so we can understand behavior, environment, what are in our lifestyle, what habits can we change. I was talking about at the very beginning how we kind of take for granted the definition. It's still getting into the basics, going right back to the beginning of defining dry eye. I think we really just kind of skate over that multifactorial etiology, but that's the root of dry eye. And that lifestyle report, I think, will really help us understand that multifactorial etiology in a lot more detail. What are we doing that we can change, right? Sometimes we're so excited in clinic to talk about IPL and thermal evacuation that we don't spend so much time on the step one: behavior, environment, cosmetics, right? Yeah. I always tell patients that this is a pyramid. And step one is the base of the pyramid for treatment. And if you don't identify what those risk factors are in your lifestyle during step one, we can't build with step two or step three because that's our foundation. So I'm excited about the lifestyle report because I think we'll really be able to emphasize that more. I mean, we understand that thermal evacuation and IPL, it's sexy, right? And we all want it in our clinics. But getting to the basics, I think we need to regroup on that a little bit more and really get back to the basics.
It is, and I think it's really wise. I love there's an analogy I heard from another doctor, so it's not mine, but it's sort of like if you're not addressing the behavior, it's like kicking your shin on like a coffee table. You do it once, your body heals. But if you do that every day, 5-6 times a day, every day, you can put medication, you can put your leg in a brace, you can do all sorts of stuff. Over time, though, it's all going to end up going downhill.
Yeah.
Like your leg, you're going to lose the leg. So
Yes, great example. Yeah.
So I think of that same thing with the behavior and understanding why somebody's developing these symptoms, the surface damage of their eye, rather than just having to rely so heavily on just these advanced medical treatments to save us.
Yeah.
So
Agreed, for sure.
thank you, Hardeep. This has been an amazing conversation. I know we have so much more we could talk about, and so perhaps we'll have you on as a guest another time. But thank you again for being here. It was a real pleasure.
Thank you so much. It was such an honor to sit down and chat with you. And I love that we have met each other in passing at different conferences. And I'm really excited about this friendship going forwards. Thanks, Joe.
So that was our conversation for today. Thank you so much for joining us. If you are enjoying this type of content, please do yourself a favor and follow us either on your favorite streaming service or subscribe to our channel over on YouTube, because that will go ahead and remind you whenever our next episode is coming out. And if you're somebody who is finding a lot of value in this content and also gives a damn about your profession of optometry, then please do us a solid favor by leaving us a review on whatever streaming service you are using. That will greatly help us out and help more professionals find this content. Otherwise, again, thank you for listening in, and I hope you have a fantastic day. We'll see you soon.